it makes
Okay, good morning, everyone. Happy Monday, happy October. Full moon today, actually. I noticed that this morning. Thank you so much for being here for the October SURSAC meeting, Substance Use Recovery Services Advisory Committee. My name is Tony Walton. I'm the chair for this committee, and I'm here today in Olympia at 626 8th Avenue with Michelle Martinez, Senior SUD Project Manager, Melissa Tomke with Communications, and Rachel Downs as well. And so we're all here supporting this committee. And we'll go into some logistics and reminders like we usually do. And then after that, we'll go through a quick roll call with the committee and then talk about the agenda briefly as well. And so thank you so much for making time today. And just in terms of the reminders around logistics, this meeting is being recorded and live streamed on TVW. So thank you for our TVW partners. The meeting recording and all relevant information like presentations, agenda, minutes will be shared on the HCA website. If you haven't had a chance to look at the agenda, it is posted on the website now, and we'll put a link in the chat. All of these meeting, the recording, the relative resources and materials are all open to public disclosure requests. So just a reminder, please do not disclose any private or confidential information. Next slide, please. Just another reminder about language and terminology. I feel like the committee is really mindful about this, and we take opportunities to educate and remind people about positive person-centered language. But just another reminder as we start this meeting today, and especially as we go into conversations that can sometimes be difficult, and people are bringing so much experience as well as passion and empathy to those conversations. And so just sometimes in getting into those that dialogue, we kind of forget about like the best way to refer to the situations we're talking about. And so just always a good reminder there as well. Next slide, please. And then public feedback. We definitely want to make sure that there's time and availability of time for feedback from the public, as well as obviously the committee members. And so we usually provide time at the beginning of each meeting and at the very end of the meeting for dedicated public feedback time. That is time for when anybody that's not a committee member can raise their hand and ask questions or provide additional input or content or suggestions. And then we also try to do that around each agenda item. So once, like, for example, we have some presentations and some information being shared today. And then once that information or presentation has been shared, we'll allow time for committee member questions or comments or feedback. And then we'll also allow for public feedback after that as well. If you are with the public or a meeting attendee outside of the committee, just a reminder that you will have 3 minutes to provide feedback, which seems to be enough time for the most part. It's amazing how much you have to be talking to fill up 3 minutes. And then also we accept any feedback and comments through our website at or our email address at hcaesv5476@hca.wa.gov. So I think that's it for our fun kind of housekeeping items, right? Or is there one more slide? No, that's it. Okay, so getting into the agenda and, okay, there we go. Next, we have committee intros. So I'm just gonna go down the old roll call sheet here and see who we have present with us today from the committee. And so Senator Dingra. Senator Braun, Representative Davis.
Good morning. I'll just say Senator Dingra, I just saw she's at an Internet Crimes Against Children task force, which I am walking out of.
Oh, awesome. All right. Well, good morning. Representative Burnett.
I'm here. I'm have to follow along on my phone. My PC won't open the link for whatever reason on Teams.
Oh, well, sorry to hear that, but glad you're here. Caleb Bantagreen.
Good morning, here.
Good morning. Don Julian Saucier.
Good morning.
Good morning. Sean Meyer. Alexi Orr.
Good morning.
Good morning, Alexi. Amber Cope.
Good morning, everybody.
Oh, I can barely hear you.
Can you hear me now?
Oh yeah, much better. Thank you. And good morning. And Brandy Flood.
Good morning. How are you doing?
I'm doing, actually really well for an early Monday morning. Thanks so much for asking. And hope you're doing well as well. And sorry, I noticed trying to multitask. I shouldn't do that. Sorry. Stormy Howell.
Good morning, present.
Good morning. Chad Enright. And John Hayden.
Good morning.
Morning, John. Vicky Lewis.
Good morning.
Morning. Sherry Candelario. James Tillett. Christine Lynch.
Good morning.
Good morning, Christine. Sarah Gillard. Danelle Tanksley. Malika Lamont.
Present.
Good morning. Addie Adwell.
Present. Good morning.
Good morning. Kevin Ballard.
Good morning. Present.
Hey, Kevin. Hunter McKim. Representative Levitt.
Good morning. I'm here.
Hi. And Representative Manjarres. All right, great. Well, it looks like we have a little bit over half of our committee here this morning, which is wonderful. So great to see everyone. Moving right along in our agenda here, and it looks like we have about got a little bit of time. But I did have some announcements from the Healthcare Authority. So I did want to speak about a couple of things, primarily government shutdown, some reassurances around there, as well as some recent good news about our federal awards. First, with the federal government shutdown, just wanted to kind of share some information that's come both through our website as well as from leadership, that HCA is closely monitoring the situation with other agency leaders and federal partners, definitely taking all the necessary steps to ensure continued operations and the stability of services and continued payment to providers. And so just wanted to put that out there, that's definitely a priority to ensure there's not a discontinuation or interruption in services. At this time, or at least as of last week, we didn't anticipate any immediate impact to our programs or impact to ability to pay providers, and expect to be able to continue to draw down on awards with no interruption to Medicaid funded services, and that individuals enrolled at Apple Health, our Medicaid program, Public Employees Benefit Board, and School Employees Benefit Board coverage, and all of those accessing behavioral health services will not experience a disruption in care due to the federal government shutdown. So I think that's a really important note to share with the committee. And then finally, healthcare providers will continue to be paid for the services that they provide amidst this federal government shutdown. So just some reassurances there and some information that I wanted to share with the committee as well as with those in attendance around the federal government shutdown. It doesn't seem like, at least as of this morning, there's any indication that there's going to be a resolution in the Senate in terms of passing an agreed upon budget. So we'll just continue to monitor the situation going forward, and while prioritizing services for Washington recipients of behavioral health as well as other Medicaid services. Like I indicated, I wanted to share some good information about some recent federal awards. If you track kind of like the federal discretionary grant or formulary grant cycle, they usually come out in September. So towards the end of September, the Healthcare Authority Division of Behavioral Health and Recovery did receive notice that we received a number of discretionary or formulary grant awards from the federal government. I just wanted to highlight two of our large ones that really go to support and sustain a lot of the services that the individuals with substance use disorder or individuals who use drugs access. One is our SUPTERS federal fiscal year 25 allotment, which SUPTERS is Substance Use Prevention, Treatment, and Recovery Services. It's our block grant. It used to be called the Substance Abuse Block Grant, and now it's the SUPTERS Block Grant. But including technical assistance as well as some supplemental funding, we received an award of over $42 million to support behavioral health services for the population that we serve in Washington State. So just a huge, very, very big news, so crucial in terms of ensuring a continuum of services across the state. And in addition to that, we also received a notice of award for our state opioid response grant. And so our state opioid response grant, previously state targeted response grant, we've had for over 7 years. And we received our notice of award for over $28 million. And that includes funding for supplemental award that was really quick turnaround. I think our team had about a week to respond to it and apply for it, but it's another additional $1 million to support access to youth housing for youth that are being discharged from inpatient facilities, as well as expanding some of the craft training that we've been talking about in this committee over the past couple of years. And so, so just wanted to share that good news with everyone. And also, if the committee is interested, or if it would be helpful to have somebody from the SOAR or the SUPTERS team come and talk more about what we do with that funding and kind of how it goes to help fill in some of the gaps and sustain services in Washington State, please let us know, and we can kind of try to make time for that at a future meeting. So moving on to the updates and other announcements, the Mentee survey. I just wanted to thank everyone that had a chance to respond to the Mentee survey that we've sent out a couple times now. We're just trying to elicit additional feedback from the committee as to how we can make time in the meetings and how we can best use this time to provide updates about progress made towards the substance use recovery services plan, as well as make time and space for other conversations. And so appreciate everyone that took time to respond to that survey. And we're currently processing some of those responses, figuring out the best way to circle around and provide updates or provide next steps based on that input that we received. And so I'm not checking the chat, so hopefully there's not like some questions in there, and also hopefully somebody is not saying, hey, Tony, we can't hear you, because I just rambled off a lot of stuff.
It looks like Brooke Davis has her hand raised.
Oh. Well, my apologies. Yes, go ahead.
Yeah, thanks, Tony. Great updates. I just a quick question about one of your earlier updates regarding the grant awards. First of all, your generous offer about having folks come to speak about SOAR or what I think you said the name change, and the artist formerly known as the Substance Abuse Prevention and Treatment Block Grant. That would be, I personally would benefit a lot from hearing about that. My question was twofold. You mentioned supplemental grants with regard to both. It sounds like you listed what the supplemental grant for sure will go to, and I was wondering, is that the bridge housing specifically, or is it a different effort that sounds somewhat similar? And then my second question is, how much supplemental of the 42 million on the block grant, what's the normal allocation? So how much extra did we get, and is that extra, what is it going to be allocated for?
All really good questions, and I want to make sure I get you accurate information in response. So let me take that back, and we can include it in the notes in terms of the breakdown, and as to what the base funding was, what the supplemental funding was for each of those awards, and we'll get you that information. I just don't have it off the top of my head. I can say I believe that for the SOAR supplemental, that's separate than the bridge program. It was a new proposal that was put forth, but I'm not quite sure how that team is planning on operationalizing that, but we can get you that information.
Okay, no problem. Thank you. Yeah, I just so happen to have I convened a meeting with the bridge housing folks, and just for the committee's edification, if folks aren't aware, the legislature passed a bill a couple of years ago that created one east of the Cascades and one west of the Cascades, basically 90-day recovery housing for youth and young adults under the age of 25 who are exiting inpatient mental health or substance use disorder treatment. And anyway, I convened a meeting with them, and then Oxford and Walker and the recovery housing folks. And I just want to make sure that sometimes state government gets so big, I want to make sure that that the right hand's talking to the left, and we're not sort of reinventing the wheel, and that we're, cross-pollinating where it makes sense. So thank you.
Yeah, I appreciate that. Thank you so much. And then I just realized that we rolled up committee member announcements and comments up into this time, and we're running out of time. So I'm just going to quickly add, I'll put in the chat the other updates that I had, which was one about a new report from research and data analysis about characteristics of people with Apple Health and stimulant use disorder diagnosis in Washington State. That was published, so I just wanted to make sure that was on everyone's radar. And then we also have, actually today at noon, so just want to get this out there, Washington Department of Health and University of Washington Medicine Program are providing an update on the Washington statewide telebuprenorphine hotline. So I'll put the registration information for that in the chat, as well as another upcoming webinar that's next week. But for right now, I want to open it up. And if Blake's here or not.
I don't think is here.
Oh yeah, we don't have Blake. That's fine. We'll
I am here, Tony. I'm
awesome.
here. Sorry.
Blake,
Yeah,
if you want to take it
okay.
away with getting some committee, seeing if there's any updates or comments from the committee, and then going into public comments, I'll get these links in the chat for everyone.
Yeah, you bet, Tony. Good morning, everybody. Blake Elson with the Healthcare Authority. And we are looking for comments, announcements, or anything that you have going in your world as far as committee members go. So I see that Rep Davis had her hand up first, and then we'll get to you, Caleb. Rep Davis?
Yeah, thank you so much. So actually, Tony just made me think of it when he mentioned a report. There was, I think we spend a lot of the time in this committee talking about opioids and stimulants, but this committee obviously is all substances. So WISIP, the Washington State Institute of Public Policy, just came out with a report that it might be great to, if I weren't driving, I would put it in the chat. But it might be great to have them present at some point. The report, we're approximately a decade plus into cannabis retail legalization in Washington State. And for the first time, they pulled data that looked at health impacts related to and associated with proximity to one's residential address and the proximity to a cannabis retail outlet. And the results are pretty damning. Higher rates of cannabis use disorder, mental health outcomes, poor mental health outcomes that are associated with cannabis use disorder, all associated simply by living near a cannabis retail outlet. And there's some real equity issues there too, because those outlets tend to be concentrated in lower income communities and communities with a higher BIPOC population. So just wanted to flag that. I've done a lot of work related to issues related to high potency THC and the health impacts and the psychiatric impacts of that substance.
All right, thank you. Caleb.
Good morning, and Rep Davis, I think I just threw that link in there. So I just want to mention around there was a news report a couple of weeks ago about a large seizure down in Centralia of about 50,000 blue pills that look like M30s that have historically been fentanyl the last 3 to 5 years that were actually carfentanil, which is 100 times more potent than fentanyl, which is 100 times more potent than morphine. So, very concerning. And we just did a little blog post that I will post here as well. I want to give you for context. So one, I think that is a indication of sort of the pressures on a drug market and the changing drug supply and how drug producers are going to continue to try to make profits. And there's a reason carfentanil would be on that list. And then another thing, just for context, I think is important is DEA has a campaign called One Pill Can Kill, which is very understandable from a prevention perspective for opioid naive folks to be aware of. And so that's one component in thinking about a response that I think is important to be aware of. The other, though, is, just with some simple math, that people could easily be using 10 pills a day. And if you take that math out, you would say those same 50,000 pills are actually only enough for 167 people to avoid withdrawal for a month if they have opioid use disorder. And so in thinking about the relationship between supply and demand, I think it's important to be mindful of that component as well about what the drug supply is representing. So just want to share that with folks. There's a blog post there. And again, just reminding folks, we have both the epidemiological data, but also some interpretation and context for that. So I wanted to share that with people because I've gotten a lot of questions on that. So there you go.
All right. Thank you, Caleb. Appreciate it. Rep Levitt.
Thank you so much. And a really good conversation. And I just want to echo Rep Davis's comment on that study that definitely caught my eye. And we've been talking about, Rep Davis has been leading on the high potency levels on THC, but we've also been talking, or in addition, we've been talking about, sign related to cannabis stores, billboards related to cannabis stores in near proximity of schools or where children are, or playgrounds, et cetera. And so I think it's time to take that seriously. I know that people talk about the medicinal benefit of marijuana, fine, but certainly the impact for mental health and long-term impact on youth. The data is evidence of the harm that marijuana causes in our state.
All right. Thank you very much. Any other comments? Malika, go ahead.
I just wanted to, this is actually a question in response to the last statement that was made by Rep. Levitt, and maybe just something for us to think about collectively as a group. Yes, there is this recent study that came out that does speak to harms. However, I don't think there's ever really been meaningful research into the benefits of cannabis for folks. And because we have such a prohibition-based stance towards substances in our country, we always look for things that will back that up rather than looking at what are the benefits that are occurring in our communities. Cannabis has been shown to help certain folks with their behavioral health issues, but we don't have a lot of research about how that actually has occurred and what the outcomes have been. And I mean, even if we looked at in comparison to, pharmaceutical substances, pharmaceutical-based substances, what are those comparisons? I mean, I think that we just need to caution ourselves that yes, it's good that new research came out, and in the broader context, the positive benefits haven't been studied either. So I just want us to be able to keep an open mind in this group. Thank you.
All right, thank you. Okay. Rep Burnett.
Yeah, I'll respond to the last comment of the open-mindedness. With my 25 years of law enforcement experience and then plus, I think if you're going to be open-minded, let's talk about the benefits, but you have to separate recreational use from pharmaceutical use and what we used to call as, prescription or, for marijuana use, whether it's CBD or if it's actually growing the plant and consuming it that way. And I think that's very timely and disgusting. And I'm all for all of those studies. But we have to look at the big picture. Society wise, have we become less dependent on dangerous drugs or more dependent? Regardless of what you call a substance use disorder, addiction, or whatever you label it, because we're not going in a direction that's favorable for our society and the families that it's tearing apart. So I think, yes, let's look at all of the different things, but let's keep in perspective of where's the needle going, where's it pointing. As we continue to look at more dangerous drugs, this group should be doing everything we can to help Washington State residents be successful in moving that needle backwards. Thank you.
All right, thank you. All right, Malika, go ahead.
I do think that we need to look at the direction that society is going in and recognize that substance use is one factor. And oftentimes when people are when people are proceeding into disordered substance use or what's described as disordered substance use, there's often a number of other societal factors that are impacting that, because substance use is a coping mechanism. And also, people recreationally use all kinds of different substances. And I don't know that I don't know what the distinction was being made between if a substance gives a person a benefit, something that's occurring in their body, but they don't have a prescription for it, are we classifying that as recreational use? Or what are we, there's just a lot of different things that we need to think about when that comes into play. And, as far as the decay of our society, quote unquote, there's a lot of factors leading into that. And I do think we need to take a comprehensive social determinants of health lens to what is contributing to the issues that we're experiencing in our communities.
All right, thank you. Amber, I see you. Just 1 second. Rep Davis.
Thanks. I'll be quick. Sorry, I didn't mean to launch a colloquy about cannabis this morning, but I do feel compelled to state there's a comment made about benefits, therapeutic benefits of cannabis to folks with behavioral health disorders. And I will just comment, I've not seen any evidence-based research to support that. The evidence is quite clear that cannabis has detrimental effects for people with behavioral health challenges. It leads to panic attacks. It's associated with suicidality and suicide completion, particularly in young people. It for people who have psychotic disorder who use cannabis, it increases incidence of psychosis, how both the frequency of those states and how long a person remains in a psychotic state. So I just want to make sure that we're talking about accurate information. And I will also say it's not accurate that there hasn't been research. There are actually 3 FDA approved uses of cannabis, only 3, and 2 of them have to do with nausea suppression and appetite stimulation in individuals receiving treatment for chemotherapy treatment. It is also true that the way that we've studied the harms is the same way that we've studied the quote benefits, and they're largely from observational studies. So we do have quite a plethora of research on the subject. Thank you.
All right, thank you. So Amber, we'll let you chime in on this one here real quick, and then we'll move on if we can. Go ahead.
It's just really quick. I just wanted to bring up NIMBYism and the fact that most cannabis dispensaries are placed in lower economic neighborhoods because people are all for legalizing marijuana, but they don't want a dispensary in their neighborhood. And so it might be that that fact would color this research as well. That's all I have to say. Thank you.
All right, thank you. All right, now it is time for public comment. Rep Levitt, did you need to make another comment on that?
Yeah, I do. Being from a district that doesn't have cannabis stores, I don't think people are all for wanting cannabis retailers in their communities. I think, at least in my communities that I get to represent and I'm grateful for, they're not supportive cannabis distilleries, or certainly expansion of them in their region. So while some may be, many are not. Thank you.
All right. Thank you. Okay. Now it is time for public comment. If any member from the public has a comment, please go ahead and raise your hand virtually. I see, Emily, you have put some links in the chat. Thank you. Anybody from the public want to make a comment? Okay, Teresa, go ahead. Did I get that right?
Sorry, I was on mute.
No worries.
It's Teresa. I
Teresa.
put it in the chat, but I'm wondering, is there any research about the decline in alcohol use versus the increase in marijuana use? Because it seems like the culture in around alcohol is definitely changing, and less people are drinking. And I just wonder if that is in that any correlation with the marijuana usage.
All right. So we'll take that question in the room and see if we can get back. Go ahead, Tony.
And no, as I say, great question. Thanks for asking it. And also, we have a guest here today, and so I kind of want to, if there's no other public comments or public questions, wanted to try to move to the next item on the agenda. So let's pull up the agenda real quick. And also thanking the committee for the really helpful conversation around cannabis use. And I'm glad Rep. Davis brought up the WISRP report, because I think it provided an opportunity to kind of share input and share thoughts about that particular topic. So we'll, capture those in the notes, and if we have time at any future meeting, because 2 hours goes by really fast, and it feels like these agendas are always jam-packed as it is, and so we'll try to make time for future conversation around that as well. With that, though, I wanted to, and I don't see the agenda. Oh, wait, what is? I don't see it up there, but I see it over here. So I'm going to go.
Yeah, recovery place Kent, secure withdrawal management, and stabilization facilities. Yes. So Teri.
Yeah, Teri Hardy, thanks so much for being here, and thank you for being patient while we got moved through the beginning of the meeting. And I saw you were on camera earlier. Are you still here with us?
I'm here and ready.
Great. Well, thank you so much, and so nice to meet you. And thank you for taking time today to share some of the experiences around Recovery Place Kent, which is a secure withdrawal management and stabilization facility. And we invited you after kind of talking about our last meeting in September, and we took back a lot of the feedback that we received. And I talked with Zephyr Forrest, the SWIMS administrator, and Luke Wagner, who oversees a lot of the ITA work. And we were trying to decide and figure out how to make time for future conversations and future perspectives around SWIMS and the ITA for SUD law and everything. And so it was just so great when Zephyr said, well, hey, I was talking to my SWIMS, and Teri would be available and more than happy to come and share some of the work that they're doing at Recovery Place. And so just thank you so much for being here. And I look forward to hearing more about the work that's happening there. And then also we'll have time for questions and feedback and dialogue afterwards.
Thank you. Thank you so much. I'm really honored to be here. So excited to share today what we're doing in Kent for SWIMS. We have been open for 5 years, and I have a presentation on a PowerPoint that I'd like to show everyone. I probably will not take a full 45 minutes, but I'm happy to answer questions during the presentation. So feel free to stop at any time. I don't need to wait for questions at the end. And again, it's an honor to be here and so excited to share with everyone kind of how we view crisis stabilization for SWIMS and how we've really changed everything about it. So I'm kind of all lit up inside to be able to share it today. I'm going to go ahead and go to my PowerPoint. And please excuse me, we have a lot of people sick here. So unfortunately, I caught a cold over the weekend. So this isn't my usual voice, and I hope that I can do my best to represent Recovery Place Kent and all that we do without coughing. So please bear with me. Everyone see it okay? Just wanted to check. We good? Okay, wonderful. Thank you. Again, my name is Teri Hardy. I am a licensed provider. I have been practicing, I'll date myself, 23 years. I am licensed in mental health and substance use. I also have an MBA in healthcare management and leadership. And again, just very excited to be here. I have done so much work in outpatient, inpatient, and ITA. So I have brought everything that I learned when I worked in an involuntary commitment facility and really looked at all the things that were positive, and wanted to bring that to crisis stabilization for SWIMS, and just happy that we're able to talk about this today. And again, please, I welcome any questions during the presentation. So at Valley Cities Recovery Place Kent, we call it RPK. We love acronyms. I know everyone is so used to them, especially when we talk about SWIMS. But we are a 32-bed facility, 16 beds for evaluation and treatment for mental health, and then the 16 beds for secure withdrawal management stabilization, which is our SWIMS program. I wanted to point out our average length of stays. Average length of stays for both programs, and we're going to focus on SWIMS today, is a minimum of 15 days. So when we're talking about kind of the philosophy of our program and what we want to achieve, we know that longer stays mean longer chances of positive recovery. So we're minimum of 15 days. And again, clients are detained under Ricky's Law. I want to take a moment to honor Ricky and also the tireless work that Representative Davis has done to be able to bring this law into the forefront and allow us to be able to have facilities that treat patients that have substance use disorders. We know that Ricky's Law passed, and we were able to look at that law and really understand how lives are impacted because of substance use. When we think of involuntary commitment, I always think about something that I was told by Representative Davis. It's not always the best choice, but often it's the only choice. So when we look at the continuum of care, we want to be able to look at involuntary commitment. When we look at how people get to a place in substance use that is where they're gravely disabled. And we want to be able to have that place for people to go when they're in crisis and when they truly need it. So, and again, in 2018, that enabled the designated crisis responders to involuntarily detain clients who were in danger to themselves or others. And we think about it the same way that we do in mental health. Danger to self or others, property or gravely disabled due to drug or alcohol, problem to secure withdrawal management. So we're able to really look at how this law started and how we're able to help people. And I can tell you I'm so grateful to be able to be part of that. We save lives. We save lives at Recovery Place Kent. That's what we're here to do. We're here to really look at each person holistically with an interdisciplinary team, treat the whole person and be able to, surround ourselves with them to be able to help them to a positive recovery. We know that we want to get people out of the emergency room. We have really looked at all of the things that we can do to get people out of the emergency room and into treatment as soon as possible. And we really review, we look at crisis stabilization. We review all of the facts that went into making this law and want to provide something different, which is treatment and programming, not just detox. We have our detox facility in Seattle. That's a 3 to 5 day program. We are much more than that. And that really it allows us to look at again and treat the whole person. We are truly co-occurring. So everyone that is here, regardless if they're here for mental health or substance use, is able to see a med provider, a licensed psych provider, to be able to, again, look at everything that's going on with the person. Everyone is seen every day by a licensed therapist, whether it's mental health or substance use, and both of our units, so mental health and substance use, stay together. So they're not on one or the other unit. Again, treating co-occurring means we treat everyone together. So they're attending the same groups, the same activities, the same classes, and kind of working and living together. We really specialize we have specialized staffing to support this model. So not only do we have, the site providers, the med providers, but we have nurses, we have our clinicians, discharge planners, activity coordinator. We have several different people on the floor all the time. We make sure that we meet each patient, spend time with them, including myself. I am very lucky to meet each patient, sit with them, talk with them. I'm on the floor a lot. It's very important to me to be with my staff. But we have just an incredible staffing model that supports the recovery of everyone here. Our mission criteria, we really have worked on this over the years. We want to make it so that we're able to get people out of the emergency room as quickly as possible and be able to get into treatment here with us. They have to have a psychiatric diagnosis, substance use diagnosis. They have to have been evaluated by a DCR. They have to be medically cleared. So, well, I've worked so long in getting people out of the emergency room, we have to send them to the emergency room to get them cleared. They do arrive to us by ambulance, and all individuals here at RPK are on a ITA hold. We have some exclusionary criteria and also something that we've worked on that we want to make sure that we are here exactly when a person needs us. Some of the exclusionary criteria, if a primary problem is not psychiatric or substance use disorder, some conditions that are difficult for us to treat, permanent cognitive dysfunction without an acute psychiatric diagnosis, medical illness that requires treatment in a medical setting. We're not licensed as a hospital, but actually as a residential facility. So it makes us hard to be able to treat acute medical situations. Also, if someone had significant wound care, dialysis, oxygen, that's difficult for us being a site facility to treat that. We do take pregnant women. We do talk about each case. High-risk pregnancy can be difficult due to the medical component, but we will talk about it. We do take level 1 and 2 sex offenders. Level 3 is usually exclusionary, but we still talk about each person that we have that comes to us as a referral. They can't be admitted primarily for forensic reasons, and everything again is reviewed by a site provider leadership before denying any admission. Just want to talk a little bit about the court process that's overarching our facility always. And again, we're here because of the Involuntary Treatment Act and Ricky's Law. We have our initial detention, which is 120 hours, our 14-day detentions, 90 and 180 days. I am able to say that we've gotten 90-day orders on our patients for SWIMS and also 180-day orders. That really is due to the incredible work that we do when we look at the court process and the charting. All of us are on the same alignment that we need to be able to chart exactly what is going on with our patients and making sure that it's correct and accurate. And they're all working together to put notes into charts. It's really important that we are aligned in that work so that we're able to, if we do go to court, have the case that we need to show that we need a person to stay. And then we also have the DCR crisis responder. They're the ones that makes the determination if an individual is a danger to oneself, gravely disabled, a danger to others, or a combination of the first 3 criteria. So every patient that comes here has a combination or 1 or 2 of those. The DCR provides a petition for initial detention, which starts the first 120-hour hold, which is business days. And then we here evaluate and assess the patient. We write the court petitions and provide testimony and evidence at hearings. I'm also a court evaluator, so it's very important for me to also really understand the law. I have a legal background as well. I used to be a Rule 9 attorney, so that really helps me to be able to understand the law and be able to understand what it takes to be able to put forth the case. And we also have a coordinator that handles all the ITA paperwork and coordination of services between RPK and the King County ITA Court. Again, a 14-day petition is filed at 2 p.m. prior to the day that is scheduled. All of our patients have a public defender. And again, this is just an overview. I'm sure everyone is very versed in this, but I love to include this so that, and for an understanding of the legal aspect. And again, when we do our 90 and 100-day orders, the burden of proof rises because the patient has been here for quite a while. We also really look at our less restrictive orders. It's an agreement by the client in the court that has certain conditions for 90 days after a patient discharges. I'll go into the statistics of how many patients that we discharge in LRO in just a few minutes. The conditions include for an LRO taking medications as prescribed, attending all outpatient appointments, staying at residential treatment, no use of drugs or alcohol, and we can also add other things to that. If an individual is on an active LRO and is hospitalized or detained again, the ITA detainment is an initial 14-day hold, which allows us to really look at how do we protect patients when they leave in case they go into another crisis, and that LRO really helps with that. I want to take a few minutes to talk about our schedule and our daily programming. Again, we wanted to change everything about crisis stabilization. We are not here to just stabilize a crisis. We're here to encourage and really, look at what will it take for each patient to have a positive recovery and to really connect to community, to provide them hope, compassion, and care that really shows them that they're able to not only work through a substance use disorder, but have long lasting positive recovery. And that's our focus. And we know that programming, treatment, and the care from all of us provides that for them. So we try to have a very busy schedule. We do a lot of groups, peer activities, all focused on DBT, CBT, mindfulness. We have a lot of yoga, a lot of walking, exercising, being able to, have the reflection at the end of the day, to have everyone kind of come together, talk about their day. What were your goals? What did you achieve? It's very important for us all to be so involved. Where a lot of us teach groups, I teach groups, kind of facilitate them. So we're all involved in their care. So it's just really important to look at what will it take for a person to be successful, and that's providing all things that we can and treat the whole person. What really sets us apart also is our recovery focused discharge plans. We really look at all the ways that we can help a person be successful. And part of that is to make sure that they're housed when they leave. I have my stats on the next slide, but happy to be able to show all of the collaborative partnerships that we have. Here at Recovery Place Kent, we take patients from all over the state. We also take patients from out of state. One thing that has really changed kind of in the last few years is having a lot of Jane and John Does come to us. A lot of them from the airport, traveling from other states. So we really work hard to be able to identify people, to make sure that we can connect them back to family. We've had some amazing stories where people have been missing for a couple of years, and we're able to get them here to be able to provide the treatment and care for them, and connect them back to families. So we're really just focused on what can we do for each person, so that they're able to be able to have that connection back in life. So we use a lot of it, we work with home and communities for adult family homes, of course, inpatient treatment all over the state. We're able to send people. We look at faith-based programs, sober housing. Each patient, when they leave, will have, a list of all the meetings in their area, all the sober supports, all the different things that they can access. And again, those less restrictive orders when patients leave are very important. We have a lot of successes here, and I love to share them. We have enhanced our clinical programming to include the great schedule that I was able to show, our streamlined process for our screening. We want to get the patients here as quickly as possible and get them out of the emergency room. We have a 30 to 45-minute turnaround from the time that we get the call to acceptance or denial, and it's almost always acceptance. We want to make sure we can help everyone. These are the stats that I love. 98.6% of our SWIMS patients discharged inpatient treatment, or a combination of adult family home and outpatient, back to family and outpatient. Again, same with our ENT, and 98% of our patients discharge on an LRO, which is a less restrictive order. We're working on 100%. Sometimes we have those court drops. We still can get patients on LROs. We still get them to housing, some kind of program. Yes, Tony.
I'm so sorry, just real quick. So the 98.6%, it says of SWIMS clients discharged to inpatient treatment, but I just want to confirm, it sounds like it's actually a mixture of inpatient, outpatient, recovery-based housing. It's not like 98.6 all go to inpatient treatment after.
Yes, and I put inpatient treatment because that's primarily where they discharge to, but they are discharging on a less restrictive order to treatment in some form. I would say so many more are going right door to door to inpatient, but it's important to show that all of our SWIMS patients are housed when they leave. Every single one is housed. That is so important to us that we're able to do that. And again, we accomplish that, and thank you for that question, Tony. We accomplish that with the length of stays being longer. I do want to share how we're able to achieve that. With the interdisciplinary team that I described, and again, all of us working so closely with every patient every day, we're able to, a lot of our patients don't go to court in the first 120 hours. They have an understanding. We start working on discharge on day 1, which means that we sit with them, we do an assessment, we make sure that they have insurance, we talk about where were you housed before, do you have housing? We have a list of questions that we're able to work through with them to get an idea of what they need when they leave. So when we focus on that, we're able to make sure that the patient not only knows that we're working so hard for them, but that we're going to achieve results. And they often get continuances. Sometimes things take a while, like adult family homes. They take probably 4 to 6 weeks. But our patients understand that we're working so closely that we will get there. We bring them along every step of the way of what we're working on. So they don't want to go to court. They know that if they go to court, it could be a chance that they could be discharged, and they would be discharged in the same way that they came here. And with the understanding of us all working together, they know that they can have something better. And it's so important for us to be a voice to patients who have lost their voice, and really, again, look at that stigma. Look at the stigma of involuntary commitment and change everything about it. We want to, again, look at it like programming and treatment. That's what this is. We're not just here to stabilize the crisis, but we want to go so much further than that. And that's why, there's always going to be the stigma of voluntary commitment, always that we're taking rights away. And we want to look at it as a chance for each patient to achieve whatever success that they need to be able to be positive in recovery. So that's always our goal. And again, those less restrictive orders, it's so important to be able to discharge on that, because we want to have people not only be accountable, but be safe. I mean, the goal here is to save people's lives, like I said. We know that an LRO will allow them to be able, if they do get into a crisis, to be able to get back into treatment much quicker, and be able to, again, start again the work that we've kind of built with them. It's really important to discharge in that way. We really focus our enhanced MAT treatment. That includes Suboxone, Sublocade, Vivitrol, and Methadone. So we do take patients on Methadone, and we're able to get them that MAT treatment right away. And that's in this next slide. I can really share that with you, what that looks like. So in the last year, from 8/1/24 to 8/30/25, we have admitted 103 patients with OUD disorder, along with other disorders as well. It could be co-occurring or polysubstance, but 102 started on MAT. I think that is an incredible statistic. We're able to get them on MAT treatment on day 1. The biggest thing that I kind of think about that with SWIMS is a myth that patients can be in a SWIMS facility for a short time, not able to get on MAT treatment, have some time clean, but, get discharged and go out and have a fatal overdose. We have fought that, and we've actually shown that that is no longer true. When you have these longer length of stays, minimum 2 weeks, and you're looking at that MAT treatment on day 1 and getting them on that Sublocade, the Suboxone, the Vivitrol, the likelihood that a fatal relapse will happen goes down to almost 0. And I think it's important to note that because we're successful in that. And this is a statistic we took all out of our EHR program, or electronic health records, to show that we are changing everything when it comes to crisis stabilization for substance use. I have time for questions. Shared a lot of information, so I appreciate everyone kind of listening, and I'm happy to answer any questions. Yes, Caleb.
Thank you very much for this. I'm curious whether you're aware of, I imagine HCA would need to do it, but what it looks like for folks in terms of ongoing connection to medications for opioid use disorder upon release.
Yes, absolutely. The other part of our discharge plan is that everyone is discharged with 30 days of meds, mental health, and substance use appointments and treatment. That's how we achieve the LROs. Any facility or agency that our patients go to have to agree to monitor that. So we are making sure that they are continuing to get the MAT treatment after discharge. That is so important. That's a focus. Also, every patient is discharged with appointments to their primary care provider. So it's not just we discharge and stop services. They're all completely set up along with that less restrictive order that ties all of that together to make sure that they have everything they need to be successful when they discharge.
And sorry, a quick follow-up. I see Susan has her hand up, but I just have a quick follow-up on that, which is Do you know the distribution of which medications, which forms of Sublocade, if they're using Vivitrol, if they're on methadone?
Which form? So the one that we go to is a Sublocade. That is usually our go-to for opiate use disorder. We do use the Suboxone as well. Methadone, we take methadone. We don't start methadone when they're here. I don't have, unfortunately, an OTP provider to partner, but we do take them on methadone and make sure that when they return to, usually when they're on methadone, they usually return to where they were from, and then we continue to partner with that agency. So we transfer everything to a partnership here at WeCare, and then we're able to transfer back.
Great, thank you.
Of course. Is another hand up? Yes.
Thank you so much for sharing these updates. And I love, as a treatment provider myself, how focused this program is on, that continuation of care after involuntary treatment. It's so important. So thank you for sharing that. I think it's really impressive that your internal reporting is showing reduced overdose deaths. That is fantastic because, as I shared last time, the research literature on involuntary treatment largely shows that there's an elevated overdose mortality kind of around the world, not just in the United States, but in programs around the world, even those that have strong universal health care behind them, like Sweden, where they have good handoff after involuntary treatment. So I would love to see a follow-up to that 2023 WISIP report that was widely published. I just haven't seen any data on overdose mortality. And that, I think, would be quite extraordinary to publish that far and wide so that people can see Washington State is doing something different. That I think that's really important first. And then the second piece is, I appreciate that this is a kinder, gentler way, a more compassionate way of doing involuntary treatment than, many countries around the world, right? Where there are struggles with providing evidence-based and compassionate care in a lot of places doing involuntary treatment. But I don't think we should gloss over the fact that it does strip people of their civil liberties. I heard kind of like, some people say that is the case, that it is the case that we are stripping people of their civil liberties. So just presenting that as such, and as you so carefully said at the beginning, this is a treatment of last resort. Let's bolster those treatments that lead up to having to do involuntary treatment. So just wanting to put that out there that, I think it's important that we're straightforward about the fact that this does strip folks of their civil liberties, but it might be necessary as a treatment of last resort to save lives. Thanks so much, Teri.
Yes, thank you. And I appreciate it, Susan. And of course, I say that, right? Again, it's not the best choice to take people's rights away. But I have to say, with the epidemic of fentanyl that we are seeing in such huge proportions, along with other things, and I did want to comment on marijuana, I do have to say, being here for 4 years, I've seen the uptick in marijuana psychosis, in particular to young people. And often they are still buying marijuana on the streets, not just in stores, that are laced with fentanyl. So we have to be honest about what that can do to young people. It can take quite a while to get someone out of psychosis for only marijuana. So it is important to note that. Again, going back to your comment, Susan, when we talk about civil liberties, when we talk about an epidemic such as fentanyl, where people are losing their lives or dying on the street all around us, I think it's important to understand that sometimes, most of the time, when someone is in that state, again, we are here to save lives. We're not here to do a detox. We're not here to do a 3 to 5 day stay. I think that a lot of things lead up to that to get a person to ITA, but it's front and center. And it is so important to have a place where people can go. And I think when we look at the care that we provide here at RPK, the focus of all of us, 125 employees that focus every day on saving lives, and we're all aligned with that vision that we can do something different to save lives, and we can take away the fact that, yes, you're here and you're not able to leave, but here's all the things that we can do for you every single day to get you to a point where you're not going to have that fatal overdose, is front and center. I think that's really important to point that out.
It's really important, though, to point out that that kind of work that you're talking about is most effective when it's done earlier on in the process in the form of voluntary treatment. Even mandated treatment is more effective. So I agree with everything you're saying as a treatment provider, again, myself, and I also work in permanent supportive housing and people experiencing homelessness. So I've seen the gamut, and I appreciate that you're working with, populations where there are maybe no other choices. And Washington State has done a great job in making sure that's when this kind of treatment is provided. So I appreciate what you're doing, but I don't think we should gloss over that, there is a stripping of civil liberties. We need to bolster the front end of our treatment spectrum before it gets to this. And I recognize, again, as a treatment provider, I see this all the time in my research and my clinical care that folks are struggling, and there's so much more we can do up front.
There is, absolutely. And I do come from a place where people have been in inpatient treatment 10, 20 times. We have to look at this as a disease model. This is a disease. Would we be telling someone if they had cancer and they wanted to leave chemotherapy, would we just let them walk out the door? No, all doctors and nurses would run after that patient. We need to look at substance use in the exact same way. And that's why we are successful.
I disagree with that. In the United States, a person can choose not to get chemotherapy. I mean, a person can walk away from treatment.
Sure, but however, would we let them? Would we let them? No. And that's why we need to look at this the same way. And we can, and again, it's not glossing over. It's the fact that we're involuntary. It's the fact that people are here and they cannot leave. But I have also shown the facts of how we have saved lives over and over again here. And that to me is most important. I'm a member of the Overdose Fatality Committee for King County, and I cannot tell you how many people have lost their lives and ITA wasn't even thought of because of the stigma that we are always fighting against. I will forever be a tireless advocate and the loudest voice in the room on the fact that treatment works. And when you look at ITA in a different way, and we provide the programming and treatment as someone would get when they go to inpatient, these are after long stays in inpatient. This is after many people. We don't get patients that have had one overdose. We get patients that have had 50 overdoses. So we have to understand that this has got to be an option for people in the continuum of care, and it is a good option for them. So I appreciate your comments. Thank you. Any other questions?
Yeah, I want to make sure, sorry, Terry, I want to make sure that we have time for, and we have a little time here for committee members to comment. Malika, did you want to comment? Sorry, I saw your hand up there.
This is just more of a comment, I guess, about what just happened. So I'm like, ITA is the last option. It should not, I think, am I hearing you recognize that, or is this, it's feeling almost like this is a promotion of we should do this more? And so I just wanted to get some clarification on that from the presenter.
I will definitely clarify that. I have stated many times, this can be the last option. What I would, and it's not a promotion. I simply wanted to share how we have viewed ITA for so long and how it's important to view it differently, to understand length of stays can be longer for people, that we can provide treatment and programming here. That is my goal today, to be able to show what we do at RPK that sets us apart from other ITA facilities. And I have to say that I have been contacted. Several states are enacting a form of Ricky's Law. It could be a different name. It could be a legislative number, but I've been contacted from several states. I've done work with Canada when Ricky's Law went to Canada. I just got contacted last week from a doctor in Alameda, California, because they passed a form of Ricky's Law. People are recognizing the work that we're doing, and I think it's important. It's not, I could promote this because it has saved lives. What my purpose here is to share what we're doing, to share our successes, to share how we can make a difference in people's lives when they need it. That's what's important.
Yes. However, what I'm hearing is that the decision about when they need it doesn't take much into consideration what the person thinks or how the person feels. It's about, there's a lot of and I understand as a last resort, I guess the prescriptive approach is what is being promoted. That is what's being promoted. However, like it's concerning to me that this notion of like people don't have choice in their care, and that it seems like we're saying that they shouldn't have choice in their care earlier on, and that it is your responsibility to make all of those decisions for people. I mean, there's a lot of things that save lives, and there's a lot of things that don't. And we don't, unfortunately, have enough of the options at the front end of the continuum, like that's not up to scale. And as a member of this group, it is really concerning to me that we are having a discussion in a way that we are looking at investing potentially or making recommendations about investing a lot of money into the last option when we don't even have a built out system for the what should be the first options.
What I can say is for this is crisis, right? So I deal with crisis. I don't look for people. I can't admit people. I have to go with the continuum of care, which is people often get here after several stays and all of the continuum of care before they get to us. So I don't have a choice who comes here. What I'm trying to say is that I will make a way for everyone to come here when they need it. That's what's important. I get all of our patients from designated crisis responders who are responsible to see if a patient is gravely disabled. I am not talking about people that, have substance use and never have gone to outpatient. We get people that have long stays, several stays in inpatient treatment, have had several fatal overdoses and lived. That's where I come in to provide something different. And we have to keep that, again, in the continuum of care when people need it.
And
If I could jump in here real quick. Tony, go ahead.
Oh yeah, thanks so much. Sorry, we were both jumping in. I see there's some more hands and definitely want to make sure there's time for additional questions and comments. I just wanted to also provide a little more context and scoping for how this presentation came to be, just in case somebody hasn't been like tracking the narrative over the past couple of meetings. This all came about, I think this committee has been really focused. We looked at the entire continuum of services, continuum of care, made recommendations based on where the gaps were. And a lot of those recommendations were on some of those upfront services, low barrier, helping support individuals who have systematically been unsupported by the systems that we have. And so I think that's where our conversations have been for 2 years. And then in August, at the very end of the meeting, Representative Manjarres brought up a really good point and asked about what are we going to do in their community. They saw a lot of people suffering, a lot of people out in the community, a lot of people who were obviously using illicit substances, probably intoxicated, and wondering what this committee has done in terms of addressing, and I believe the word was either getting them into treatment. And this was on the coattail ends of the federal administration releasing a very scathing executive order on forcing individuals into civil commitment and policing and homelessness. And so there's been this kind of narrative coming through. And so it was the executive order happened, and then Representative Manjarres had questions about what this committee has done in terms of recommendations for forcing people into treatment. And then so at the last meeting, we had what was intended to be an overview of the SUD ITA system. We had a great conversation again, a lot of different opinions about this, a lot of different comments. And then we wanted to bring in additional perspectives and additional input into the conversation. So that's why Teri was invited here to talk about the work that One Swims facility is doing within Washington State. I don't want all of that to be misinterpreted as the committee making new recommendations or the committee going in a different direction, because the committee under the RCW had a task to develop a substance use recovery services plan, and then make progress towards implementation of that plan. And as you all know, that plan does not include anything about involuntary commitment or treatment for individuals who are using drugs. And so we are limited and scoped to that plan. And this has been an attempt to broaden the conversation and make space and time to ensure that we are also talking about these other pending, really important aspects. And I think it's important context when considering the plan and considering the progress we're making towards that plan. But just wanted to clarify, this is not in any attempt to make space for further recommendations for the committee. I just think it's really important to scope that. The committee was tasked with something, the committee put forth the plan, and now we're monitoring that plan for the next year and a couple months now. All that to say, really good conversation, really great perspectives, and it's obvious that this is something that is important to everyone, and we're trying to make space for it the best that we can. And I know there's other hands up, so I just wanted to provide that additional context before we went further, just because I feel like maybe that was missed a little bit. And I didn't do a good enough job kind of introducing Teri and then also indicating it as like a continuation of that work that's been happening over the past couple of meetings. So, all right, Blake, back to you.
All right. Thank you. Rep Levitt, please.
Thanks so much. And again, really appreciate the presentation and learning more. A couple of questions, if I may. One has to do with utilizing, related to Ricky's Law, and ensuring that we're utilizing all the beds available, and how do we do that? And the second has to do with a follow-up to a meeting that I had with some district court judges in Kane County and other areas, Kitsap, et cetera, and a concern for cuts in funding for drug therapeutic courts. Because if there are a cut in funding, there's fewer people going through those avenues, which have been successful for the most part, versus directly to being incarcerated without treatment. And so could you comment on what you know about either one of those, and what you're aware of being work being done on both fronts to shore up both funding, or how folks can advocate for funding in Kitsap and King County, in particular Kitsap, they're about to get cut, or no additional dollars certainly for the work they're doing on therapeutic courts. Thanks.
You want me to answer that? I'm so sorry.
Yes, please.
Yes, please. Thank you.
Okay, so therapeutic courts, I know that, and it's so interesting you say Kitsap. That's one of our big referral sources. And again, I want to say that we accept patients from all over the state, including Eastern Washington, Spokane, and Whatcom are our highest referral sources. So we work with every single county every single day. Regarding funding, you know, there's so many things going on, and the therapeutic courts, you know, are there. But we're looking at, you know, where is someone at in their journey and what has brought them to us. So I can speak to, again, the work that we do here, how we get our patients. Often some are in therapeutic courts and have, you know, had, you know, their disease kind of, you know, again, go further than what is needed in an outpatient setting, and their ability to take care of themselves is at risk. So that's how they arrive to us. But we have people on court orders. We have people that come to us directly from jails. We try to look at everything that we can do to help whenever is needed. So I can only speak from the patients that we get and the work that we do in our communities. I'm not sure if that answered the question, but I'm not sure if I have all of the answers for what you asked me. Did you have anything to follow up that I missed on that?
No, not entirely. I mean, it's kind of an unfair question too, because I don't expect you to know everything about what's happening with therapeutic and drug courts. But then also in terms of bed utilization for Ricky's Law, how we can, it's a great policy, and so how do we increase it? And I'm sure Rep Davis probably has thoughts on that. So I'll
Yes, well,
stand down.
what I
Yeah,
can do,
thanks.
I can tell you that I could do this several times over. It's difficult when we're at capacity, and so we try to make a way to have everyone in as much as we can. But we're always at capacity at Recovery Place Kent. It's important to be there when patients need them, but sometimes we do not have a bed. We're a smaller swims facility and hope to expand. I think it's much needed, and I want to replicate this model because I know that it works.
Thank you. Rep Davis?
Yeah, thank you so much. You know, I appreciate Tony's comments trying to clarify. I mean, so to be clear, like, Teri's not here to defend or promote the involuntary treatment system. Teri is an operator that is implementing state law. The laws of the state of Washington, we have substance use ITA. Teri is a provider of that. That is what she was here to talk about. And I will just say that Teri Hardy is doing a hell of a job. I have personally had more than one loved one receive care in Teri's facility. Excellent care, life-saving care, which prompted long-term recovery in all cases. I also just want to ask you, Teri, I mean, to be clear, very much a leading question, but, you know, one of the comments that's frequently made about substance use ITA is like, basically, person is not going to get better until they want help. And so I'm hoping that you can speak about some of the conversations you and I have had about the transformation that you see in your patients, where you see people overwhelmingly converting to, you talked about it a little bit with people requesting continuances. Obviously, at the outset, when someone's initially detained, it is against their will and it is, you know, taking away their liberty. That is absolutely correct. But if you could talk a little bit, just, you know, anecdotally, qualitatively, what you've seen in terms of the conversions to voluntary care and just that, you know, window of willingness and that sense of hope and willingness to receive care returning. And I was also hoping you could speak a little bit about outcomes you've seen in patients with alcohol use disorder. We talked a lot about, you know, mortality associated with opioid use disorder post-release. But, you know, when we look at all-cause mortality, I'd be curious what types of outcomes that you're seeing with patients that you treat. I know you treat a lot of patients with alcohol use disorder.
Absolutely. Thank you so much, Representative Davis. I appreciate your support always, and always thrilled to be able to talk with you and work with you. Again, when we talk about how the continuum of care works and patients wanting to work with us, I think if you bring a compassionate, holistic approach that everyone on an interdisciplinary team aligns the same way, you're going to have results. And that really is showing patients that you care, that you are here solely for them, and that you're not here to focus on, you know, kind of outside things for them. You want them to focus on exactly what they can do day to day, to really look at the disease concept, what their life has been like, and what they want to do different. Because of that great work that we're doing. And again, you have to have a vision aligned with everyone. Everyone has to buy in, or, you know, what we're trying to do for treatment is not going to work. And we're very fortunate to have that here. And when you provide that to people and look at the holistic approach, and you're providing everything that can, you know, be there for them, they're going to want to continue. So again, very few of our patients want to go to court. It is their right. Everyone, you know, can have their day in court, but they choose to continue, and that is their choice. They're the one who has to talk to their attorney. They're the ones who have to make that choice to be able to do that. They also have to be willing to accept the less restrictive order. That is their choice. We provide the information, we provide the care, we sit with them, we work with them. It is their choice in the end to want to stay and also leave on a less restrictive order. Nothing is forced, you know. Again, you can take away someone's right and you can still provide the very best care for them. Again, as Representative Davis said, this is a state law. I'm here to provide the best treatment possible within that law. And that's what I think is important to say. If we have that in place and we have facilities that are designed and slated to do that, then we're going to do the very best, and we're going to do it in the very best way possible. And I think that's what sets us apart. We do treat quite a few people. It's not just fentanyl, of course. That is number one, and that has increasingly been so. But alcohol use disorder is the second, of course. And with that, you know, we get them through the withdrawal protocol. That's why they come here to do that. But then we go beyond that, and we're able to really, like with any substance, look at the disease concept and what can we do to align all the parts in your life, the physical, emotional, spiritual, and everything that you have going on, to align with being able to be successful. We look at harm reduction. We always do. We meet people where they're at, not where we think they should be. So all parts of that continuum comes into play when we look at, you know, our discharge plans. How are you going to be successful? We don't look at a one-way approach to recovery. We can't do that. There's so many different ways. You know, there's 12 steps, of course, but that's not the only way. We look at all the things that a patient is willing to do for themselves to be successful. When you have that buy-in, you're going to have patients and meet them where they're at, and they're going to see that success is possible because it's their plan. And I think that's why, you know, that sets us apart. I hope I answered your questions.
Yes, thank you so much, Teri. Very much appreciate the presentation and the answering questions. There are a few more questions in chat. If you feel comfortable answering those, they're spread out amongst there. But again, thank you so much. I'm going to take a quick second here. Thank you. And take a quick second here for any public comments. We are over time, but great conversation. Any public comments on this? So just we can.
Just want to say really quickly, I'm going to put all my information in the chat, including my personal cell phone. I'm on call 24/7. You can call me anytime. I really mean that, because I take calls 24/7 hours a day. What I want to do is invite anyone who would like to come and see our facility. I will give you a full tour. I will take you on the units. I think it's important to bring that perspective to anyone who wants to come. I do tours all the time. I think it's important to educate and show the community and community members and everyone here how we do the work that we do and why it's different. So anyone that wants to come and see our facility and go on and have a tour, please reach out to me.
Thank you so much. Appreciate it.
Yeah.
Tony?
Yeah, thanks so much, Terry. I appreciate your time today. Looks like one specific question that hasn't been addressed is, and I believe the answer is 100% state funding, but where is the funding for swims derived from?
Yeah, absolutely. I can speak for our facility. We have a contract with King County. So King County will pay for treatment if a patient does not have Medicaid or insurance. So if someone is not able to get insurance in any way, King County will pay for that. We do take Medicaid, Medicare, and private insurance. So that is paid for through those different lenses. But again, we do have a contract with King County. With that, we don't have, we're not 100% full of King County residents. Again, it's important to meet everyone where they're at when they need treatment. So we work all over the state with DCRs to bring people in, but we do have that contract.
And I think the other comments were clarification around cannabis laced with fentanyl. It doesn't sound like that's been seen at all in Washington State. So I think there was a comment about that. And so just kind of clarifying, there was a follow-up question if there's been any lab confirmed cases of cannabis laced with fentanyl, and then Caleb confirmed that they've seen zero evidence of fentanyl laced in cannabis in Washington State.
Sure, I can speak to when we do our fentanyl. We test everyone that comes in for fentanyl, and so we have two things in someone's system: marijuana and fentanyl. With the patient being very surprised. Now we can only go on what they say, but that they say they have never done fentanyl, that they have no idea how it has gotten there. That's where those reports come in. That is something that we see.
All right, thanks for clarifying.
Of course.
All right, well, thanks again. Thanks so much. And we do have to move on. I mean, because I don't want to move Brianna to next month twice in a row. That would just be rude. so Brianna.
I'm sorry. This is Rep Levitt. I just need to comment on I'm sorry, and I'll be brief, but there are cases where cannabis is laced with fentanyl. Lucas Petty in my district, a young man who died 3 years ago. We just passed the Lucas Petty Act in 2024. He had marijuana laced with fentanyl and died. And I know of several other youth where that's happened as well. So the notion that it's not happening in Washington is simply not factually true.
All right. Tony, would you like to introduce Brianna?
Yeah, I'm so sorry. We do need to move on in the agenda because we only have about 40 minutes left and a lot of content to still cover. Thanks again, Terry, for your time today. It looks like, can somebody pull up the agenda? I forget what we have slated next.
It's the RNP quarterly report update for
Brianna,
quarter one.
Thank you so much. Great. So we're going to a shift here, from going to talking about, voluntary treatment and secure withdrawal management to Recovery Navigator program, which is all about meeting individuals 100% where they're at in the community, pre-booking diversion, whatever services and individualized service plan that they kind of determine at that time. And so we try to bring quarterly updates to this committee. It is one of the tasks of the committee per the RCW is to continue to monitor the data which are coming out of the Recovery Navigator programs administered by the Behavioral Health Administrative Service organizations, and then making recommendations, providing feedback. And so always appreciate the conversations around our RNP work that's happening. And Brianna, thank you so much for making time today and presenting and taking time to build a report and a summary of what we're seeing with Recovery Navigator program.
Well, thank you, Tony. Appreciate the intro. Good morning, everyone. Thank you for joining me today. Today we're going to be going over the Recovery Navigator quarterly report covering quarter one of 2025, that it's from January to March. Before we dive in, as always, I want to take a moment to acknowledge the collective effort of our case managers, law enforcement partners, community organizations and outreach team. The work they do is complex. They face many challenges, but we also see real impact of individuals accessing services, engaging in recovery, and making positive changes in their lives. As we go through this, and I'm going to try to go as quickly as I can, I would like for you to think about what stands out to you the most. Where do you see areas that we can have some progress, any gaps, or any areas of further improvement? We are consistently collecting feedback from this group to inform future updates of the data collection and the reporting process. You can go to the next slide. So today, the overview of the presentation, we're going to do a quick overview of the Recovery Navigator program, as well as providing some insights for referral and outreach data, case management, and data work group updates. You can go to the next slide. This is just a quick table of the future dates that I will be reporting. And I know it's a little off, so I apologize. This was supposed to be last month. But, October 2025, I will be reporting again in December, March, and June. And those are the subsequent dates for which I will be reporting out on. You can go to the next slide. So for those that are new here, the new members, new attendees from the public and from the committee, the Recovery Navigator program was enacted through Senate Bill 5476, the drug possession law from the state versus Blake decision in 2021. It codified RCW 7124-115, and it is a criminal legal system diversion program that provides behavioral health and other supportive services to individuals who intersect with law enforcement, either due to simple drug possession or other criminal infractions. This includes individuals who have frequent contact with the legal system, social contact, referrals from first responders, and others who are referred from community and outreach sources. The RNP framework is modeled upon core components of the law enforcement assisted diversion, or LEAD, and incorporates peer support, harm reduction, and trauma-informed care principles to support the individual throughout their recovery journey. RNP is a statewide effort in partnership with the Behavioral Health Administrative Organizations, BHASOs, to provide community-based outreach, intake, assessment, and connection to services for individuals referred to through pre-arrest, pre-booking diversion, and community referrals and outreach. The structure looks differently depending on community needs. In less populated counties and neighboring regions kind of share the resources, while larger urban centers may have more than one provider. RNP has also created career pathways, especially in rural areas where those with lived experience and recovery can translate into meaningful employment in behavioral health. Can go to the next slide. This is a quick map of the RNP. These are just like highlighted, like the regions that we have an RNP program. We do service all of Washington, but the stars are where those are the areas and where those RNPs are located. So you can see some kind of are in between, and some have more than one. And you can go to the next slide. So in Q1, we saw an estimated of 2,869 unduplicated individuals who engaged through the referral and outreach throughout the entire state for RNP. Of those, 496 referrals came directly from law enforcement. This highlights the program's partnership and the role in diverting individuals from jail or emergency services towards a supportive alternative. All of the almost 3,000 individuals contacted, 30% of those enrolled in the case management program, either through light or intensive. We'll kind of go through that more later on. The response time is another critical measure that we have here, and it is 65% are responded to within 15 minutes. All these numbers that you see here on the screen are all based on the unique clients, which we continue to refine through the data system improvements. So these are individuals, though we might have had many contacts with those individuals. I pulled those specific referral reasons tied to those 2,869 individuals. Next slide. This slide reflects the demographic information for those same 2,869 individuals. The purpose here is to get a better understanding of who we are serving across race, ethnicity, gender, and taking these demographics helps to ensure R&P services are equitable, reaching rural and urban communities alike, and reaching those underrepresented communities. You will notice a large number of that refused and not provided in the race distribution. Uh, while this gap limits our ability to see the full picture right now, this highlights exactly where we can strengthen our outreach and data collection moving forward. To address this, the program is improving demographic data collection earlier in the process. We're currently working with the Lead Support Bureau to refine outreach practices. We are learning from other low barrier programs about how they collect demographic data at first contact. And we're also enhancing provider training and system improvements to capture demographic fields more consistently. You can go to the next slide. Looking at case management, which summarizes services for the enrolled participants that we receive in the program. We recorded 15,565 case management events during Q1. That is about servicing about 3,068 unduplicated clients that are actively engaged in case management. So to break this down further, from the referral and outreach, about 417 are newly enrolled in case management. These individuals may already have some stability, but still benefit from check-ins, resource navigation, and connection to community services. Light case management often includes periodic phone calls, ensuring follow-through on referrals, or addressing specific barriers such as scheduling an appointment or applying for benefits. 270 clients from referral and outreach were enrolled in intensive case management, and these clients typically need a higher level of support, things like frequent in-person contact, coordination across multiple providers, helping with housing or legal issues, assistance navigating complex behavioral health and medical systems, and usually involves ongoing support and long-term stabilization needs. In Q1, there was about 5,625 case management. Oh, no, yes. Oh, yes, sorry. So what I did, because there was a comment last time from Malika who was talking about the breakdown between light case management and intensive case management and those events between those individuals. So what I did, taking that feedback into consideration, what I did is I broke it down for you for the purposes of this meeting, and I will do so, and I will continue to do so for the other presentations as well. So in Q1, there were 5,625 case management events serving 1,825 light case management clients, averaging about 3 contacts in that quarter per client. Additionally, there were 9,729 case management events serving 1,750 intensive case management, which averages about 6 contacts per client. This is a little bit higher than the last time that we saw it, but it's still fairly low. in terms of, contacts within a quarter. Now, we have had frequent contact and conversations with the BHASOs and their providers, and we are in conversation about, how are we capturing those and if those are accurately reflected. We kind of got a little bit of both. Some regions were like, no, that's pretty accurate, and some were like, actually, no, it's not that accurate. We actually meet with them more often. And we kind of saw that there may not be that capture of indirect client services. So as our workbook is structured currently, not able to capture more of those like just check-ins as opposed to providing referrals in those meetings. So we are looking at ways of updating the workbooks to be able to reflect accurately what they are doing, even if those are those indirect client services, where there just might be a check-in, a phone call, or what have you, other than referring them to services in those meetings. So it's a continuing conversation, and we'll continue to bring it back up here in the quarterly reports so that we can monitor that as well. As you can see here, the highest of the direct care services is at peer support, followed by recovery goal support, client supportive services, transportation, and appointments. The referral services main were the basic needs, housing, community support organizations, and SUD referral or public benefits. You can go to the next slide. This is the breakdown of the demographics for the case management. As you can see here, the refused or not provided is a lot smaller than the referral and outreach. That is due to that rapport building that happens with within case management. So we're able to collect more of that. Though it's still quite a bit of a larger number. We are still again working on updating our processes to make sure that we can capture all of that information. Yeah, what's important to highlight is, for the race, the refused and not collected, it dropped from 33% in referral and outreach to 22% in case management. And for gender, the refused and not provided went from 21% in referral and outreach to only 4% in case management. Go to the next slide. I'm trying to go quickly because I have another presentation after this. I'm sorry. So stop me if you have questions. Our data work group continues to focus on strengthening program reporting and improving the accuracy of information shared with this group and other stakeholders, along with our legislative reporting. The key activities this quarter where we were preparing for the next workbook update and system update into PDAMs. Providers and BHASOs completed a survey, and our team met to review the results, discuss any concerns, and explore options for data improvement collection. The data team is also analyzing feedback and workbook outcomes to shape the next version as we plan to roll out in January 1, 2026. In parallel, the internal team is creating a desk manual and training materials to support providers with a new workbook and data collection standards. We're also looking at the PDAMS system update. The business analysts and the PDAMS team have interviewed all the providers. The system will restructure how data is collected and validated, and that current timeline rollout is about 12 to 18 months, probably 2027 time range. We are constantly looking for process improvements, reviewing and refining how client counts are collected and how data is reported on the dashboards and these reports. We are collaborating with HCA's behavioral health data team and research and data analysis division at DSHS to ensure consistency, transparency, and clear communication, both in these reports and the training materials. The overall objectives of our group is to reduce data gaps, standardize reporting across providers, and enhance program accountability and provide more reliable data to guide decision making and demonstrate the program impact. You can go to the next slide. And here's if you have any questions or comments. What I will say is that the next time that I report out on will be Q2. And during that quarter, I tried to cover the whole entire fiscal year. So if there's any areas that you guys would like to see some trends or, some trends even from last year to this year, would be great. You can send those to me. You can put a comment in the chat, or you can email Ryan or myself, and we can incorporate those into the next presentation.
All right, questions from committee members?
Oh, I see Grace. The data team is working on tracking referrals from prosecutors to RNP in addition to law enforcement referrals. So we are tracking law enforcement referrals. We are updating our workbook version 7 because we noticed that there was a lot more of that interaction from the court systems and prosecutor's office to RNP. So we are updating to make sure that we can track those accurately. So thank you for the question. Yes, we are working on ensuring those items are tracked.
Yeah, and just to provide some additional context to that and background, as a reminder, like when Recovery Navigator program was first enacted, it did not include that pretrial diversion pathway that was added in 2023 as part of passing of 5536. And so that's why that wasn't originally a referral source that we tracked, because at that point it was really at the law enforcement intercept, maybe community-based intercept, and then the scope of the program was considerably expanded as part of 5536 being passed.
All right, any more questions? Brianna, you may be up again.
I am.
All right. Tony, any context for the next items?
Brianna's going to provide some context, so hopefully this isn't duplicative. Just a reminder, I briefly talked about this earlier in the meeting, that one of the main tasks and goals of the committee is to, monitor implementation of the Substance Use Recovery Services Plan. We've tried a different couple of ways of trying to bring a draft of the plan to the committee. I think one year we went through it. We actually presented it on the screen and like kind of went through like section by section, and that seemed a little clumsy, or not clumsy, but just not the best use of everyone's time. And so we're trying another iteration of bringing updates about the plan to the committee, and I'll pass it off to Brianna to talk about that.
Thank you. So again, as Tony was saying, as a reminder, in the RCW, HCA, in consultation with this committee, is required to submit an annual progress report on the implementation of the Substance Use Recovery Services Plan through December 2026. The 2025 progress report is currently in draft and will be submitted to the governor's office and relevant legislative committees at the end of the year. This presentation covers just a few of the highlights and key updates from the report. The areas that, there was, some progress and ongoing challenges and what's next. SURSAC members will get the full report here. I'm hoping by the end of this week. You'll get a link to the SharePoint site where you guys can provide comment and feedback on there. You can also provide comment and feedback to the email addresses listed at the end of this presentation, which will also be sent out to the group. And the next slide. Sorry, Rachel. Appreciate you keeping up with me. So the first part is we're going to go over some treatment highlights, including health engagement hubs, the opioid treatment program, and medications for opioid use disorder, MAUD, in jails. And go next slide. So the Health Engagement Hubs pilot program expanded from 2 to 5 sites in 2025, and those are the 5 areas listed below: Bloom and Heart to Heart, Health Point, Sound Pathways, Lumi Counseling Services, and Yakima Public Health. These hubs are designed as welcoming low barrier entry points, offering health and social supports in one place. Through 2025, the evaluation team met extensively with state partners and each site to shape the data collection and evaluation framework, ensuring we're measuring what matters most for the people that we serve. Next slide. So Washington State continues to see significant demand for opioid treatment programs, or OTPs. 2 new OTPs are currently being built, one in Wenatchee through Acadia Healthcare and one in Walla Walla through Oregon Recovery Treatment Centers. However, expansion continues to face local zoning challenges. Some cities and county zoning ordinances still prohibit OTPs, even through the RCW 3670A 200, identified them as essential public facilities that cannot be lawfully restricted. To address this, the Washington State Opioid Treatment Authority has been meeting twice monthly with the Attorney General's office to review and respond to cases of OTP or MOUD patient discrimination. This coordination is helping us tackle system-level barriers to treatment access. Go to the next slide. Again, I'm going fast, so I apologize. The MOUD and MAUD in jails program continues to grow, with 23 jails participating statewide through fiscal year 2025. These programs provide access to medication-assisted treatment while incarcerated, a critical step for continuity of care and overdose prevention. As several jails transition to the Medicaid Section 1115 reentry waiver, ongoing program funding remains essential to support consistent treatment during reentry. This expansion continues to close the treatment gap for one of our higher at-risk populations. And there's a chart of the total number of MUD services provided in fiscal year 2025. You can go to the next slide. In addition to expanding treatment, we're also improving on how we collect and report data, which has been a major area of focus for this committee as well. So we'll briefly look at 2 key system initiatives: the PDAMS update and the DDIP. You can go to the next slide. So PDAMs are Program Data Acquisition Management and Storage, it's a mouthful, data platform set to roll out in 2027. This system will help provide consistent statewide tracking of services and outcomes for Recovery Navigator program and address our data validation concerns, raised by SURSAC to those individualized numbers and care. And there's also a legislative report that was submitted in December 2024 that identified major data gaps, particularly around statewide substance use prevalence and how individuals with SUD interact with law enforcement and service systems. And hopefully when the PDAMS is implemented, we'll have one area where we can, pull our data and hopefully significantly strengthen our ability to evaluate recovery outcomes over time. Next slide. So the DDIP, or Diversion Data Integration Platform, in 2023, under the RCW 7124-908, HCA was directed to develop a diversion data integration platform, a shared database to track diversion efforts across programs like Recovery Navigator Program, LEAD, and arrest or jail alternative programs. HCA submitted a Blake response budget request to support implementation, but unfortunately that request was not funded due to statewide budget constraints. We've provided this information to the Governor's Office, Office of Financial Management, and the legislature that without funding, this platform can't move forward at this time. While this is set back, the need remains clear, and we will continue to elevate this as a key recommendation for next biennium planning. You can go to the next slide. Beyond treatment and data, the SURS plan implementation also focuses on how we engage with individuals early on, before, during crisis, through outreach and diversion programs. These efforts are to reduce criminalization, improve access to services, and create safer, more supportive pathways to recovery. Go to the next slide. We'll talk about the Law Enforcement Assisted Diversion, or Let Everyone Advance with Dignity grant program. Has doubled its recipients from 4 to 8 programs statewide. This includes King County and Seattle through Evergreen Treatment Systems and Ideal Options, Jefferson County through Gateway to Freedom, Chelan and Douglas counties through Catholic Charities of Yakima, and Marysville through Second Chance Outreach and Hope for Homies. These programs provide an intensive case management for individuals who use substances, helping connect them to care, reduce recidivism, and stabilize their lives. LEAD continues to be a model of community partnership and compassionate, evidence-based diversion. Go to the next slide. And so beyond LEAD, we continue to collaborate with the LEAD's Peer Bureau, the Washington State Association of Sheriffs and Police Chiefs, Behavioral Health, the BHASOs, and community partners to expand pre-book diversion programs statewide. These efforts reflect one of the plan's goals to provide alternatives to arrests that link directly to services rather than incarceration. These partnerships are crucial to sustaining long-term system change in both local and state level. And here's a map kind of breaking down the arrest and jail alternatives, where LEAD locations are and RNP programs are located in Washington State.
Hey, Brianna, if you don't mind jumping in,
Yes.
we have
Yeah.
a question from Rep Levitt, please.
Brianna, thanks for the great work. Quick question back to the community providers. How are you ensuring that they're using the dollars as intended and that the dollars are getting directly to clients and the client needs? And then how are you ensuring efficacy? We've just had some, high profile headlines in the Seattle Times and News Tribune and others of nonprofits taking the money and squandering them, or in some cases fraudulently taking dollars, or in some cases doing incredibly nefarious things with these dollars, and the treatment isn't happening, or folks aren't getting served. So how are you ensuring the efficacy and outcomes and delivery for taxpayer dollars?
Brianna, I can take that.
Tony, if you want it, yeah.
No, great question. I mean, it looks a little different for each of these programs. Like, so for example, arrest and jail alternatives, that's administered by WASPIC. The Healthcare Authority has a contract with WASPIC and the Criminal Justice Training Center for the administration of HAA programs. Obviously, we have a number of contract monitoring processes and policies in place when we have a contract for public funds, federal funds with any of our subrecipients or contractors. And so that's closely monitored, and we work closely with WASPIC to see how that funding is being operationalized on their end. The LEAD program, those are all direct contracts between the Division of Behavioral Health and Recovery and the 8 sites, the 4 sites that Brianna had up on the presentation, as well as Thurston County, Mason County, Snohomish County, and Whatcom County. DBHR has been overseeing and administering these sort of community-based contracts for years now, and we have a number of processes and policies in place to ensure that we have contract monitoring to oversee how the funding is being used, the certain deliverables that we ask in terms of performance-based contracting, and then we're collecting data, obviously, for both those programs as well as the Recovery Navigator program, and so use those data to help drive any sort of decisions or oversight considerations for the programs. The Recovery Navigator program, I didn't get to that one yet. That is administered to the Behavioral Health Administrative Service Organization, so the 10 BHASOs across the state. And actually, this map that's on the screen is broken down by those various BHASOs. And so we have a very large contract with the BHASOs and a whole team in Medicaid Programs Division that monitors that contract. And then we have contract monitoring processes in place, like on a biannual basis, as well as quarterly and on other frequencies, to ensure that we're working closely with the BHASOs to operationalize and implement the programs in alignment with both the RCW as well as the identified contract language that was developed to support that program. Most of the, like I indicated, some of the funding goes directly to counties for the LEAD programs. A lot of the funding goes to behavioral health agencies that are licensed and, through the Department of Health. So then there's another layer of oversight from DOH that's not specific to the program, but is specific to the facility, and the facility works with DOH for that oversight. And then there are the community-based organizations that receive funding as well.
Thank you, Tony.
We only have 4 minutes left, Brianna, so
I
I don't
know.
know. I don't know how you want to. What's after this slide? Let's move forward. I'm gonna. Okay. And then we have the opioid awareness campaign for youth. And you know what we'll do is, just because we only have 4 minutes, so sorry, Brianna, I'm just going to jump in here and try to wrap a bow on this. We'll send out these slides to the committee, as well as we'll have them on the SURSAC webpage as well. And so, Rachel, when you go to the next slide after this, and not to limit the importance of the opioid awareness campaign for youth. Incredibly great work happening. We have some bullet points here, and definitely not meaning to gloss over any of this other work that's happening. It's just unfortunate that we didn't have enough time today to get to all of the amazing work that is going on that supports the Substance Use Recovery Services Plan. Rachel, if you can go one more slide, one more. These are the next steps where we really want the committee to weigh in and provide input. So we had some highlights. We were able to go into depth on some of those highlights, not all of them, and again, apologies. And you'll actually, all the committee members will receive a full copy of the SURS plan progress report. I don't know, Brianna, how many pages is it?
I think we're up to 40.
So 40 pages, not a light read, but I mean, informative and engaging. And so we're going to put that on our SharePoint site. And I don't know if we've had a lot of activity or a lot of people using the SharePoint site, but it's there. And we're going to actually put the document on the SharePoint site. We'll send out a link, and we'll try to give as much time as possible, like our timeline, what did it say? Like a week, 2 weeks? Mm-hmm. A week to 2 weeks for a review. And so we really wanted to use this time to kind of give like a trailer version of the SURS plan progress report, but all committee members will have an opportunity to actually review the report in its entirety. And we welcome, appreciate, and need your feedback and questions and comments so that we can ensure that this progress report that we provide to the legislature, the governor's office, and OFM is taking into consideration your input. Next slide. And then, as always, Brianna's contact information and 5476, our general inbox. I think more likely the communication with the SharePoint link to the document will come from Shell, maybe Brianna, so keep an eye out for that. And Brianna, I'm so sorry for just stepping in and kind of moving through your slide, I just noticed we were running out of time, and I wanted to be mindful of everyone's time. But really appreciate you being here. And did I miss anything that you wanted to add?
There's a comment in the chat about non-members getting a link as well.
Oh, thanks for flagging that. Yeah, we will definitely send a link out once it's finalized. Unfortunately, we do a lot of legislative reports, and they go to the legislature, OFM, the governor's office, and this is one report where we're directed to work in partnership with the committee to get their feedback, but we really don't have built into that process nor timeline public feedback, because really we're reporting on programs that have data in place and have been operating for at least a year now. But I appreciate the question. We'll definitely share a final version out with this, make sure and share a link hopefully in January or February. It's not due until December 1st. However, we have historically submitted a little bit late. It is quite the process to get one of these reports approved at the agency level and at the state level. And so appreciate everyone's patience with that. And I'm so sorry that we ran out of time. There's not really any time for any questions or comments from the committee. We'll have to send out a draft November agenda by email, so keep an eye out for that. But if anybody in the committee has any thoughts about, actually, I think we have a pretty jam-packed November agenda, right?
We do, and yeah. Did you want me to review what we are likely to have?
If everyone's okay with just staying another couple of minutes, we can review the November agenda real quick. I know that we have Casey Beck from the Oregon Criminal Justice Training Commission. It's not called that, it's called something different. But the Oregon version of that, coming to talk about their deflection grants. What else do we have?
Ryan Moran.
Oh, yes. Brian Moran will be joining us, the Healthcare Authority's new director. It started back in August 16th.
Mm-hmm. And then potentially provider presentations from health engagement hubs, sites, and OTP expansion updates.
A deep dive into health engagement hubs and OTP expansion. And so, with that, there's some flexibility. So I think, welcome the committee's feedback on how to make time at the next meeting to maybe continue the conversation around involuntary treatment and substance use disorder, or any other ways to make sure that we use these 2 hours to the best of everyone's time and make it a helpful meeting. With that, appreciate it. Thanks for being here. Hope everyone has a great rest of the day. And we'll see you and rest of the week, rest of the month, and we'll see you in a month, the beginning of November. And so thanks so much and take care.